Good morning, everyone. This is Gary Greenswag, and thank you very much for being with us this morning. We really have a very special uh, grand rounds this morning in two parts. Part one, we'll talk about pulmonary function testing in the era of race adjusters and what problems those arise and how we hope to solve those. I think people will remember maybe a year and a half ago, we were having a similar conversation about EGFR and race adjusters. Uh, this is a follow-up to that project led by Dr. Sagar and her team. Thank you, Dr. Sagar. And for better or worse, more complex. And I think that's what you'll hear about this morning. In the 8 to 9 time frame on the West Coast, there is a special Zoom for persons of interest that sort of is more of a dialogue and a workshop as to what the plan is, because it's not, shall we say, fully baked. With that, I'm going to introduce all of our speakers today. And Dr. McGinn, good morning. Welcome back from the dentist, and we hope you're
Thank
feeling
you. Thank you.
good. But let me introduce the rest of our panel. Dr. Bhakta will be our first speaker and the only speaker in the first hour, and then there are several other folks who will join him in the second hour. So Dr. Nirav Bhakta is an associate professor of medicine and pulmonary critical care at UCSF. He is Director of Education and Associate Director in the Adult Pulmonary Function Laboratory at UCSF. He is the Vice Chair of the American Thoracic Pulmonary Function Testing Committee, and so you can see that that's an important person for us to have on this call. He was recently co-chaired the ATS workshop on race and pulmonary functions that led to a publication in 2023, the ATS Statement to Promote Equity in Pulmonary Function Testing. Dr. Tom Vendenga is the Chief Medical Officer at French Hospital in San Luis Obispo. He's been a pulmonary critical care physician for 27 years. He trained at the University of Colorado for internal medicine and pulmonary critical care and received his MD at the Washington University of St. Louis. Tom is going to lead our panel once Dr. Bhakta finishes his talk. Next, we have Dr. Jeff Sipple, who do you want to show your skiing slide there? Who is a telemark skier? That's good. Who's a we would like to see you too. Good. Who's a telemark skier in Colorado? He's the associate director for clinical services for the pulmonary division at the University of Colorado. He spent many years in Montana, and then, like most professionals, traveled to Arizona, Tennessee, Colorado, and Oregon for various aspects of his training. In 1999, he rejoined the University of Colorado full-time. He loves clinical informatics, population health, epidemiology, jazz music, and telemark skiing. He hopes to traverse the continental divide several times this summer on a bicycle. So good shape. Dr. Susitra Pillai is an assistant professor of interventional pulmonology and critical care at Creighton University and medical director of respiratory therapy at CHI Hospitals in Omaha. And she is an active member and contributor to the American Association of Bronchology and Interventional Pulmonology. And last but not least is our very own Dr. Robert Bob Wiebe, who serves as the Chief Medical Officer at Common Spirit Health. As Chief Medical Officer, he provides senior executive and strategic leadership for quality, patient safety, clinical service lines, physician engagement, clinical research, medical informatics, and clinical data science. And in his spare time, he's a decent guy as well. Dr. Wiebe is committed to achieving clinical excellence by reducing unwarranted variation through evidence-based practices, engaging physicians, fostering interdisciplinary collaboration, and advancing health equity. So with that, this is a wonderful panel. Thank you all. Let's turn this over to Dr. Bhakta.
Thank you, Gary, for all those introductions, and wonderful to hear about all the great things, including jazz and skiing. All right, welcome everybody. The title of my presentation here is Rethinking Pulmonary Function Tests Beyond Race, Unraveling the Past, Paving the Future. I'm Nirav Bhakta, and I have the big task of getting us all here on the same page, mainly in terms of how we got here with lung function testing and where we could be going. And I recognize that we have a diverse audience here, so I'm just going to get going with telling us all about what is spirometry. So spirometry is the core pulmonary function test, or PFT, lung function test. And basically, we're quantifying the volume and flow of air moving in and out of the lungs. We ask someone to get on a mouthpiece, like in the upper right here, and ask them to take a deep breath in and blow out. We can measure the maximum volume of air that comes out forcefully in that first second when they exhale. We can measure the total amount of air that comes in, the forced vital capacity, the FVC, and then we can take the ratio of those two and look and see, well, how fast can the air get out of the, compared to the total amount of air in the lungs? Why are these numbers important? Well, it might not surprise you, whether you're a pulmonologist or not, to know that the FEV1 and FVC, these core spirometric measures, are related to things in the lungs. For example, in smokers, the risk of having symptoms related to COPD, developing lung cancer, risk of having emphysema, even having heart disease if you're a smoker. You also might not be surprised that in lung diseases, it's related to mortality and morbidity, although maybe a little bit of news is that it's often poorly related to even respiratory symptoms, and may not do as well as some other variables, or may not be related to other pulmonary variables that we don't consider typical PFTs, like oxygenation and ventilation of CO2. These numbers are also related to, in certain cases, exercise capacity and the ability to tolerate certain types of treatments or benefit from certain treatments. But you will maybe be surprised to learn that lung function is actually very much independent of any lung disease related to cardiovascular disease. Moreover, it is related to all-cause mortality. So cardiovascular disease, cardiovascular mortality, and all-cause mortality. And in a number of studies over many decades, this relationship is independent of a lot of variables, including blood pressure. And in some studies, it's even better than blood pressure after adjustment for everything. So lung function is important for all of us, whether we're pulmonologists or not. The way that lung function has been used clinically and in research studies in these settings here has almost entirely been through a race-specific approach. So here I'm going to tell you how that works. In the race-specific approach, the data that you collect on a population of lung function, you categorize it into groups based on people's racial or ethnic assignments. And when you do that, you can see that here in this more recent data set, which is representative of a lot of data sets over many decades, that if we look at FEV1 here versus age, that there is a characteristic rise and fall as we expect as people grow, and then a decay as people age, but that there is a residual difference after adjustment for height and age between racial ethnic groups, where in most data sets, the people labeled white or Caucasian are higher than people labeled African American or Black. This way of categorizing lung function has a lot of implications. So let's take an example here. Here's a 47-year-old female who's 5 foot tall, 5 inches. We put her on the spirometer, and the measured FEV1 is 2 liters. Next, we compare it to a reference equation. If we use the GLI African American reference equation, we'll say, well, we expect a person like this to have an FEV1 of 2.53 liters. So we'll compare her number to that, and we'll get a 79% of that value. And we'll also say that the z-score, which is the number of standard deviations away from that value, is minus 1.46. As with many tests in medicine, a threshold is assigned for normal versus an abnormal result. And often, as in other tests, in pulmonary function testing, the 5th percentile is used. So we want to know where this person lands in regards to a line that tells us that 5% of the population has a value less than or equal to this value right here. So that is 1.93 liters. So 5% of the population has a value of 1.93 liters or less. This person's value is 2 liters, which is above that. So we're going to say, hey, it's normal. On the other hand, if we chose to use the GLI White equation, we would say that this person has a FEV1 at 68% of the expected value. Their value of 2 is less than the GLI White lower limit of normal or 5th percentile of 2.31 liters, and we're going to conclude that it's abnormal. This decision that we created by categorizing lung function into racial ethnic groups has real implications, because then we have to choose that reference equation. And as you can see in that example, you might then have a different answer to questions like, should we be considering respiratory disease in this person? Will additional tests be done? Should we refer them for a lung transplant evaluation? And so on. Now, there were very few voices that challenged this race-specific approach to pulmonary function testing. All of us here, we basically came onto the scene when it was a done deal. We inherited this practice. We were told that it's the right thing to do. It increased precision in medicine. It was tailoring our approach to the person's background, and that to do it another way would be wrong and backwards. But these voices grew, especially in recent years, as we learn more and more, and the challenges to race, that list grew longer. So shown here are some of those challenges. Race is not uniformly defined across time and location. It can mask modifiable risk for reduced lung function disease. It's not a proxy for genetics. We know that variation in the genome within races, categories, is much larger than between these categories. These are limited categories. I showed you 4 on a couple slides ago, right? And they do not account for the effects of acculturation and mixed backgrounds. They can't be really applicable to everybody in the world, the diversity that we see, even in our own practices here in the United States. And that these residual differences in lung function between race categories have been used to justify an idea of innate inferiority. By 2019, momentum was gathering to examine race in pulmonary function testing due to increased attention on race and racism in our society, particularly the United States, and in many clinical algorithms, particularly EGFR. And so then in 2020, members of the ATS committee, including the PFT committee that I'm on, identified the need for a workshop, and we invited a diverse group of participants, all listed here wonderfully, including my co-chair, Christian Bime. And we then were able to, a few years later, publish this statement that I'm going to review in the next few slides. This group was wonderful to work with, just shown here. They included people covering many different areas of pulmonary medicine: COPD, interstitial lung disease, lung cancer, adult and pediatric pulmonary, many levels of training. We had people, person from Africa, from India, Canada, mostly the rest from the United States. And we had people that were expert in environmental effects on lung function, expert on the genetics, of lung function. So a wonderful group. One of our first sessions in the workshop was led by Dr. Lundy Braun, who fortunately joined our group and published this book in 2014, wrote many articles over the year, is an expert, a scholar in the history of medicine, the history of race in medicine. And in that discussion came out these important points. Views that racial categories reflected innate characteristics drove the organization of pulmonary function observation into those categories while ignoring other factors that can influence pulmonary function, as I'll show you. This disproportionate emphasis on race limited an understanding of the determinants of pulmonary function, and the majority of research that formed the evidence base for those reference equations for the lower lung function in non-white populations did not examine socioeconomic status. They didn't collect that data, report it, or include it in the analysis. Physiologists justified race from differences in the ratio of limb length to chest height. But importantly, this view is quantitatively insufficient. And we know because chest height, standing height, and the ratio of those two change across generations, we know that it's expected to reflect the environment, whether nutrition or other things. So it's not a reflection of genetics. It's even body size is not innate. This is an example of how this thinking in the past led us astray. There was a survey done of Civil War veterans led by Benjamin Gould, published in 1869, that was cited heavily for many, many years, even 100 years later, as evidence for differences in lung function between racial ethnic groups. He was asked to do a survey of a lot of different measurements, including lung function, and categorized people as white, African American, or mixed race, and made these detailed tables and showed that lung function was different between these groups. One of my colleagues here at UCSF, Dr. Aaron Bao, went back to the paper and did a reanalysis of the data and showed that if you look at vital capacity versus height and look at three groups of people shown in the blue and green, African American and mixed race individuals, in the red, white individuals, he showed that the vital capacity overlapped between African American and mixed race and was lower than people that were categorized as white. And this is important because at that time, the social class, the environment, the discrimination that people experienced, where they lived, what they had access to in society, was very similar for people that were mixed race and African American, right? But many people that were mixed race could have very little African American in their ancestry, yet they would still experience the same social situation that African American people would. And their lung function overlaps and is different from people who are categorized as white, even though they may be genetically quite similar to them, thus highlighting that social and environmental structures are likely very important in determining lung function. In one of our sessions in the workshop, we looked at determinants of pulmonary function and reviewed many evidence-based determinants, including early life factors such as prematurity, infections, nutrition, both over and under nutrition, secondhand smoke, indoor and outdoor air pollution, discrimination and stress, and even, yes, genetics. And importantly, we separated genetic ancestry versus single nucleotide polymorphisms because the former is confounded by cultural and environmental influences. These effects can have different effects on lung function depending on where in life they happen and what happens after that. Sometimes lung function can go down and catch up. Other times it goes down and then stays low for the rest of life. This is another important type of evidence that shows the importance of social and environmental effects over genetic effects. And this is a study of successive birth cohorts from pre-1920 all the way to 2000. And shows that across these successive birth cohorts, FVC and FEV1 are increasing here, in both never smokers and smokers, and FEV1 over FVC is decreasing. This is not enough time, right, in a population for genetics to change. And so the conclusion here is that there must be environmental impacts on lung function. Now I'm going to review the key pieces of evidence that we were fortunate were published after the workshop and while we were writing the report that informed the key recommendation to switch to a race-neutral equation. This is another paper by my colleague, Dr. Baugh, looking at the spiromics observational cohort in COPD study. So in these individuals who are either have COPD or at risk for COPD, they related respiratory symptoms, the St. George's Respiratory Questionnaire and the COPD Assessment Test, or the CAT test on the right, they made an association between that and lung function and showed that at every level of lung function, the relationship to symptoms is better matched between people who are categorized as white in blue versus African American in the kind of purplish color, when an average reference equation is universally applied as a single standard across both groups, rather than when race-specific equations are applied at the top. So the lines diverge at the top, but are overlapping when a race average is used. Another piece of evidence for the MESA study from Dr. El-Malai-Sachs, showing that the 10-year cumulative incidence of chronic lower respiratory disease-related events overlaps when you use a race-specific or race average reference equation for all racial ethnic categories shown here. So prediction is similar between these two approaches. Dr. McCormack did a study here in the NHANES data set, and there were a few other studies like this showing that when you look at survival, population survival versus FEV1 expressed as a z-score, so the number of standard deviations relative to the expected value, that you have a different prediction of survival when you use race-specific equations on the left. However, on the right side, when you use a race average equation, there's much better overlap in the prediction of survival at every level of lung function. So you might say rightly that, hey, great, this is amazing evidence, but how does that relate to how I use lung function for the patient in front of me in the clinic? I don't use lung function to predict symptoms. I just ask them about their symptoms. I don't use lung function to predict mortality in the clinic for the patient sitting in front of me, or whether they're going to have an infection or a cough in 10 years. Well, here's my answer to that, and it's a health system and a population health view. We have limited medical resources, right? And one of the things that we really do use lung function for, if you think about it, is to develop a concern for the patient sitting in front of us. When we see those stars on the report, red lines, less than signs, they're red flags in our mind, and we look at that patient differently, for better or for worse. And what do? Well, we might get a CT scan. We might say, hey, I need to see you back in the clinic here in 2 or 3 months, whereas the other person will say, go back to your primary care physician. Or, I don't think that we need to worry about this shortness of breath or cough that you have. It's not the lungs. Go see your cardiologist. Or we might say, you need to come back for another spirometry in a few months because we need to see if this is an active process. And so what we're doing is we're allocating medical attention and resources. And what that data that I showed you shows is that in order to equitably allocate attention, medical resources, to people who have an equal prognosis of having a bad outcome in their life, something bad happened to them, using a race average reference equation, universally applying it to all both groups of people here. So, this data is especially relevant to Black and white persons in the United States, but we do think that with more work that this can be generalizable, and that work needs to be done. But it shows that as a health system that we can equitably allocate the resources. And so from all of those considerations in the workshop and beyond, our core recommendation was to no longer report or interpret PFTs using race or ethnicity. And from that core recommendation stems the recommendation to use GLI global, which is an average reference equation across those 4 racial ethnic groups. We recognize that this is not truly race neutral in its construction, but it's race neutral in its application, in that one does not have to select a race category to apply it. We recommend no adjustments for DLCO or lung volumes, even though that there's not a race average reference equation available for those. We stress the importance of longitudinal data to see if there is an active process going on, rather than solely relying on the comparison to reference equation. We are grateful for the similarity between reference equations in FEV1 over FVC, which is important for the assessment of obstructive airway disease, such as COPD. And so you don't have to worry about that in the switch to reference equations. And we want people to embrace uncertainty in individual patient factors when interpreting PFTs. And also, race and ethnicity still have a role in understanding the impact of structural racism on lung health in research studies, in population health studies, but we don't recommend using it in the pulmonary function lab or in the clinic when interpreting and using PFTs. Just to review the quantitative shifts here, look at the graph in the upper right. The race average equation, of course, is going to be a line in between the lines that I'm showing you here. And that means that the predicted value for GLI global and its lower limit of normal are going to be values that are higher compared to the African American and Southeast Asian equation and lower compared to white and Northeast Asian equations. Thus, the application of GLI global will yield relative values such as z-scores and percentage of predicted on those reports that are lower compared to the African American equations and higher compared to the white equations. And again, FEV1 over FVC will have relatively little change. When thinking about the clinical implications, it's important to think about what is interpretation of a PFT for all of us here. One is the bulk of what is in textbooks and guidelines. We call something abnormal versus the lower limit of normal, and then we put the pattern into a physiologic bucket: obstruction, restriction, or air trapping. It has limited clinical utility in certain situations, okay? The other, a more expansive view, is the integration with the other clinical information, like I've shown here. And then in administrative domains, it's important to ask, well, what questions is one trying to answer? Work safety, effective work exposure, and so on. And then there are research and population health uses of PFTs to make predictions for groups, risks of harm from certain treatments, mortality risk. And PFTs can also define inclusion criteria for disease severity, safety, and likelihood of response to therapy in clinical trials. I want everyone, when thinking about how they're using PFTs, to ask, well, what is the evidence for any one of these goals, for any specific symptom, imaging finding, disease, job, exposure, or PFT threshold? And you might find that there's not a lot of evidence for a lot of these things. And then what measure of body size, if any, should we use? We don't know. We use height right now because that's the best data that we have. In the report, we review specific examples such as non-invasive ventilation for respiratory muscle weakness, evaluation of ILD, life insurance premiums, where shifting from a race-specific equation to a global equation will lead to a different, a person crossing a threshold, a decision-making threshold. So I point to you to review that. Here's an example, a very specific one, where a switch from a race-specific approach to a race-neutral, race-average approach will lead to a better relationship between asthma control in Black children and lung function. So here, people who have an ACT score that is bad, meaning less control, will have lower lung function in a race-neutral approach. So these are the red people depicted here that shift into that category. And so there's a better relationship between asthma control and lung function in Black children with a race-neutral approach. And there's a much lesser shift that happens in white children. And the same is seen in white adults with this change in reference equation, that overall the shift is smaller in white individuals than in Black individuals. And I think my final clinical implication and final slide here is that this is another important example that we raised in the workshop report of something to be aware of. So I showed you just in the previous slide an example where shifting to a race-neutral approach leads to a better appreciation of disease severity in Black individuals. This is an example to be aware of where shifting the reference equation in the system to a race-neutral equation has the potential to exacerbate known disparities in lung cancer care and outcomes in Black individuals in the United States. And so in this study here, the investigators sent out a survey to 225 thoracic surgeons of a 71-year-old woman with a right upper lobe biopsy showing non-small cell lung cancer. And they asked the surgeons then to evaluate the person for lobectomy. And in this person, the clinical scenario was set up so that surgery would be possible, would be recommended by the guidelines, and could be curative for the person with no N2 disease, a PET negative scan. And they found that, and also importantly, this is very important to know, the survey included a photo of the person, and the photo was a Black person. And so it's important to know that this survey and the results captured not only the impact of using a reference equation, but of what a person thinks when they look at this person's picture. And so there are biases in here, which hopefully are averaged out because people were randomized to be given one scenario or another. So they were given 3 scenarios. One where they were all the same case, but one where the GLI African American equation was used to represent the patient's lung function. The other where GLI other, an average reference equation, was used, very similar to GLI global. And another where GLI white equation was used. And interestingly, surgeons recommended lobectomy less often when the GLI white equation was used, which, as I told you earlier, would lead to a lower lung function being presented for this individual. And they were more likely to recommend a lesser resection or radiation. And so even though there are limitations to this study, it's important for any system to recognize the potential implications of changing reference equations and know that there are ways to mitigate this risk. Thank you to the audience, all my colleagues that have worked with me on the workshop report and in other endeavors related to this, the investigators that did all the great work to contribute studies to help us make this recommendation, of course, the patients who contributed their data and who are going to be impacted by this.
Dr. Bhakta, that was a fabulous overview of a very complex topic. It's interesting because back in the 1990s, when I trained and first learned how to read pulmonary function, we, said age and height and sex, and then they said race also factors in. And one of your panelists, Charlie Irvin, who is on that ATS paper, I went to him specifically and said, why is race in here? And he just said, it's a problem. So, I'm glad we're tackling it. It's taken years and years. I guess one of my first questions to you, specifically, Dr. Bhakta, is there a group of disease categories that this affects the most, or is it just across the board?
I'll say that one of the categories that it can affect is severity classifications. It's challenging to say diagnosis. One of the main places where pulmonary function tests are used in a diagnostic way is in COPD. And fortunately there, with FEV1 or FVC being the key diagnostic criterion, there's very little impact on the choice of reference equation. But disease severity is impacted by the choice of reference equation. And that can influence people's decision-making in terms of whether to refer a patient for rehabilitation. And again, for better or for worse, many studies have been done using percentage of predicted of lung function in COPD, looking at the benefit of certain treatments. Examples include endobronchial valves for lung volume reduction in people, and of course, prior to that, surgical lung volume reduction. And so it can have an impact there. And then it can have an impact also on inclusion and generalizability, sort of matching a patient to results of studies looking at interventions for IPF and other interstitial lung diseases as well.
So here's a question for Dr. Sipple, because at University of Colorado, they already made the change. How has it affected your practice, Jeff?
We'll talk a little bit in the next hour about this, the logistics of this, and all of the confluence of other things. There's been a question posted about the updated ATS ERS guidelines, and we kind of did many things all at once. So I'll just say in a very positive way, it has not affected us. And that's because of the complexities of the emotions of switching from gold, if you will, to the updated ATS ERS. So hasn't been a negative at all.
Yeah, do you one of you two want to comment about the like the interpretation itself? I know that gets in really into the weeds of the Z-score of how that might affect interpretations.
I think that's a great point because it highlights that while we have this focus on the shift in values based on the shift in reference equation, many systems, when doing this, are actually going to experience shifts in how they grade the severity of any lung function decrement compared to expected. They're going to have shifts that go beyond the impact of change in reference equation because of the use of Z-scores rather than percentage of predicted. The Z-scores do avoid age and height related biases from the percentage of predicted. And based on the ATS 2022 recommendations, it collapses severity classifications to a lesser number of categories, a normal and then 3 mild, moderate, and severe. And previously there were up to 5 different categories based on the percentage of predicted. And so we have seen already in our system that that is a major shift. And so I think it should make people realize that certainly don't blame things on a shift in reference equation, that the issue is much larger than that. There will be these other shifts. The other thing to recognize is that if reference equations are switched across the system for the other tests like lung volumes and diffusing capacity, many systems are going to experience big shifts in those too. Because the people are using very old sets typically for lung volumes and diffusing capacity. And if they move to the GLI set, especially for diffusing capacity, they're going to see a change for a lot of their patients in a big way. And that's not even anything to do with race, because even the GLI reference equations for DLCO are all derived from people who are labeled Caucasian, white, or European ancestry.
Yeah, and I just want to level set something real quick because you're really alluding to it, and maybe Dr. Peely can really comment about this because she's another really esteemed pulmonologist. When you're looking at pulmonary function tests, Suchitra, can you comment about, like, you really have to look at the patient and the clinical context and not just the numbers. So any, advice to the panel or the audience here?
Yes, absolutely. That is a great point. And Dr. Bhakta touched on a lot of different clinical implications. But when it specifically comes to the patient, you really have to individualize and personalize medicine these days. Especially, I can speak to interventional pulmonology applications. This was already mentioned when it comes to lung valve placement. We're really shifting towards non-invasive, minimally invasive treatments for so many conditions. And I think in that way, more patients might need lung valve earlier in their course of disease. More patients may be more, lung transplant referrals, as well as lung cancer. With robotic technology all across Common Spirit now, we're doing robotic bronchoscopies and targeting early stage 1 and 2 lung cancer as much as we can. And a lot of those patients, curative surgery may be precluded based on the previous GLI, non-GLI reference equations that we were using. And I think that is the hope, that we can get most of these people to the curative, box or category. So I think, you have to look at every single patient and then apply this new method of looking at PFTs, and it might make a significant clinical difference.
Tom, do you mind if I jump in and follow up on that a little? And
you bet.
just like we for Jeff and Suchitra, but what do we do about looking back, particularly as primary care physicians who may have had patients? You may consider, wait a minute, that this person, 6 months ago was told they had a normal X, Y, and Z. Do I need to go back and restudy them? Or any thought maybe on I don't know, has anyone practically thought about that in terms of given the changes here, we should go back and look at some of our patients, or is that unnecessary to do?
Yeah, so Dr. McGinn, I'll throw in one answer here. We have all of the patient's historical data captured in discrete data so that we can pull it up. And so I think that a little bit unlike cholesterol or high blood pressure or diabetes, where it's truly a numbers game, we have to match the PFTs to the patient. So what I tell all of my patients is just because we might read a number as normal or not normal doesn't necessarily mean there's a problem here. So we try and take that longitudinal view in patient-specific fashion as opposed to in the statistical fashion, which I think is a reasonable approach.
Great answer. Jeff, I got a question for you. It came from the crowd. At University of Colorado, you obviously already implemented this. Did you do, like we are doing here at Common Spirit, an educational rollout? Did you kind of educate everyone on this? Or did you just kind of just do it?
Yeah, so we'll talk about this in the next hour, but we took all of our pain at once. And so what we really did is we focused on what were the most emotional topics for the clinicians. And we just kind of had the audience, our audience, if you will, triaged the pain and suffering for us. And so this one was lower on the list as far as magnitude, and the ATS-ERS was a much more fiery subject, shall we say.
Yeah, so let's talk about what we're doing here at Common Spirit. Dr. McGinn, maybe you can start the comment. How are we approaching this?
Well, whenever I hear that question, I then turn around and ask Ankita Sagar to answer the question. So how's that for an answer?
There, that's a good one.
That's a good one.
Love it.
That's like the best answer. And then Dr. Weeb maybe. So we'll go to the two of them because they're more on the front lines of this, I think, than me.
Sure. And I can sort of preface the conversation and hand it off to Dr. Reed. Under our clinical standards portfolio, we've really been very fortunate to be able to partner with both of our engineering teams, our pulmonary teams, our facility CMOs, and IT to be able to look at it from a much larger lens, because as it was alluded to earlier, this traverses that care continuum. It affects patients that are in the hospital, but it also affects patients that are on the ambulatory side. So what we're trying to do is to really, raise awareness. So this is our first big launch to say, this is an important consideration, both clinically, but also from the lens of justice and equity. And it mirrors our mission and our values very closely for Common Spirit Health. So within our realm, we think that awareness and then working with each of these teams to see what is the best path forward to update software and hardware and then get the communication plan going would be ideal state. I'll hand it off to Dr. Reed.
Thanks, Ankita. That was a great response. I think, we have a wonderful experience with our rollout of the changes in EGFR, and the work that Ankita and Gary did to roll that out, I think is sort of the playbook that we'll use for PFTs. And again, it's about letting folks know in advance why we're doing this, sharing the evidence, but then also dealing with some of the potentially unintended consequences to put them at ease. So again, I think if we take that playbook from EGFR, it'll serve us very well going forward.
I'll make a comment that this is going to be a big challenge. We have 563 pulmonary function machines and spirometers in our system. About half of them can make the switch fairly easily or with a mild software upgrade. The other half cannot. So this is going to be a challenge for us across the system, but that's why we've formed a team to kind of do that. A question that I have back to Dr. Bhakta, you have to have seen the New England Journal article of like 2 weeks ago about I have it right in front of me, the implication of race adjustment in lung function with disability. If you want to make a comment about that is an interesting paper.
Yeah, terrific. Yeah, I could also show the slide of that so everybody's on the same page about it. But Here it is, a real tour de force work, and just noting that the first author here is a medical student, right? Amazing, but a terrific paper. And, you know, we highlighted a number of areas, right, where things could change for a person depending on which reference equation was used. They used multiple large population data sets, including NHANES and the UK Biobank, to quantify the number of people, right? The proportion of people that shift across these thresholds. And very sorry here, it's early in the morning here and I'm at home and I have a dog in the background. But, so shown here on the left are the different thresholds that they examined, including COPD severity, occupational qualification for firefighting, AMA medical impairment ratings, and VA disability ratings. And on the right is shown how people shift. And people shift in the way that you would expect it to, based on what I showed you, how a race-neutral reference equation fares compared to the race-specific ones. And then they also quantified the dollar cost that a population might experience in terms of VA disability payments. The important thing to recognize in this paper is that they took the changes in these cohorts, NHANES and UK Biobank, right, proportion of people, and then they scaled them up to the makeup of the US population. And so there's an assumption there that you can do that, right? And so I'll take one example, and that's the firefighting one, where if you say that you do that and now 2 million people are going to be out of a job of firefighting, it's not quite like that, because not everyone in the United States who could apply to be a firefighter wants to be a firefighter, right? A very small number of people do. And there's a huge selection bias. The people who go and want to become firefighters represent a particular type, a group of people. And if you went and looked at whether people shift among candidates for a firefighting job, I predict you will find that it's far fewer people are near the threshold that the firefighting companies have than if you just look at the population as a whole and say how many people shift across that line of, say, 70%. The other thing is for the disability payments, and they make this point in the paper, the numbers sound big in the end, like that there will be an additional, say, $1 billion going to one group, to Black persons, and $500 million going less to another group of white persons. But it represents a very, very small proportion of the overall VA budget, the military budget, the US budget. It's a very small number. And so, yeah, that
go
is.
Ahead, go ahead, Nirav. So I guess my follow-up question to that is, it sounds like the VA populations, Dr. Pili, you have a big VA population. Any thoughts moving forward after you saw this article?
Yes, I think that the number of VA beneficiaries from disability might go up just based on the severity category. And I think that's the critical part. I don't think that the number of diagnoses is going to go up, but I think that definitely it's going to kind of almost shift their severity stage a little bit. And same thing for lung cancer. I think there's going to be more people in that population that might qualify for curative surgery. So there's going to be some implications specific to the VA population, disability, as well as severity of diagnosis.
Yeah, and to Jeff, Dr. Sipple, I mean, you've been doing this for a little bit. Have you had to reevaluate people?
We haven't. I just chatted with some of our local colleagues involved in this, and the short answer is no. I think that both Dr. Pili and Bhakta highlight it's really tough taking a population-based statistic and applying it to an individual. We, of course, do it, and it's on one hand relevant, but it is problematic. We all probably know of people who have normal pulmonary function tests yet qualified for pulmonary disability. So I look at it as there's not a right or a wrong here so much as updated definitions, and it's still imperfect.
Great. This has been a fabulous discussion. Dr. McGinn, any final comments or?
No, I just want to thank, once again, I'm always, impressed with, you know, everything that we're doing here at Common Spirit and working with our colleagues at UC and UCSF. And thank you guys for joining us. And this is just one of those moments in time where you say to yourself, let's just do this, whatever the barriers are, whatever the issues are, whatever the cost might be, you know, we're just going to forge ahead and take care of it. You know, with, you know, Dr. Weeb and Dr. Segar's, you know, leadership, we'll make all the changes that are necessary. So I think we'll just sign off there, and I really appreciate everybody joining us today.